Assalamualaikum and good day, IB to everyone. We are from Good Ed. We will be presenting about steroid-sparing regimen for management of oral immune-mediated disease.
So what is oral immune-mediated disease? So there are a large group of immune system diseases and a large group of the diseases. So there are also has directly and indirectly that associate with the immune system. So immunologically mediated diseases that affect the oral mucosa always present with inflammations and loss of epithelial integrity through a cellular and or humoral immunity-mediated attack on the epithelial connective tissue targets.
The overall goals of treatment of immune-mediated diseases are to relieve symptoms, preserve organ functions, and control the autoimmune process. Meanwhile, the challenges in the treatment of autoimmune diseases are the complexity of symptoms, the need to manage long-term medication for preserving organ functions, and the long-term adverse effect of immunosuppressant drugs such as steroids. Corticosteroid plays a central role in the treatment of oral immune-mediated diseases. They act as an anti-inflammatory and immunosuppressant. Corticosteroids are divided into systemic and topical corticosteroid. The adverse effects associated with the use of systemic corticosteroid have led to the increased use of topical corticosteroid, but they still have some local and systemic adverse effects which arise both from their long-term use and abrupt discontinuation. With long-term use, corticosteroid can cause altered response to physical stress, steroid withdrawal syndrome, infection, gastrointestinal ulcer or bleeding, and many more. Thus, to overcome the adverse effect of long-term use of corticosteroid, steroid-sparing agents can be used in replacement therapy or as adjuvant therapy in the management of oral immune-mediated diseases. Next, I will tell you what is steroid-sparing regimen. So the use of non-steroid immune suppressive drug that permits partial withdrawal of corticosteroid is known as steroid-sparing therapy. To that, steroid-sparing therapies are simply additional non-glucocorticoid immunosuppressive drug permitting partial withdrawal of glucocorticoids and no mechanism-based approach in improving glucocorticoid sensitivity or producing glucocorticoid beneficial effect which reduce adverse effects has been identified. There are some examples of steroid-sparing agents which include azathioprine, cyclosporine, dapsone, tacrolimus, and Metatrixis. The first steroid-sparing agent that we will be discussing today is azathioprine. Azathioprine is a purine analog used as a steroid-sparing agent. It is a prodrug which is converted first to 6-mercaptopurine and then to 6-thioguanine, which is the active metabolite. Azathioprine acts during the aspects of the cell cycle and inhibits the formations of adenine and guanine nucleotides. Azathioprine is converted within tissues of mercaptopurine, some of which is converted in turn to 6-thioguanine triphosphate, which is a metabolite of azathioprine by the addition of an amino group. 6-thioguanine triphosphate modulate activation of RAS-related C3-botulinum toxin substrate 1, as known as RAC1, when co-stimulated with CD28, inducing T-cell apoptosis.
Let's talk about the complications or the side effects of azathioprine. So one of the warning of this medication is that it increases your risk of developing low blood cell counts, such as a low white blood cell count. It also decreases the activity of your immune system, thus increasing your risk of getting infections. And it also induces stomach problems such as nausea, diarrhea, and also vomiting. But do take note that azathioprine oral tablet doesn't cause drowsiness, but it can cause other side effects such as what I've mentioned just now.
Now I'm going to continue with the pharmacodynamic of azathioprine. It is a potent immunosuppressant which functions through modulation of RAC1 to induce cell apoptosis. It is one of the most frequent adjuvant in treatment of bullous pemphigoid, along with dapsone, which will be explained later, at doses ranging from 1 to 3 mg per kg. It also has a long duration of action as it is given daily and a narrow therapeutic index, so patients should be counseled regarding the risk of malignancies of skin and lymphomas. Next, the toxicity of oral median lethal dose LD50, which is a measure of lethal dose of a toxin, is 2,500 mg per kg in mice and 400 mg per kilogram in rats.
So for the usage, azathioprine act as immunosuppressant and to treat inflammatory conditions. For example, like pharyngeal surgeries and also anti-inflammatory arthritis.
Next is cyclosporine. Cyclosporine is an immunosuppressive agent with anti-T cell lymphocyte activity. It forms a complex with cytoplasmic cyclophilin and blocks its ability to activate calcineurin. Activated calcineurin normally phosphorylates NFAT1, which is a transcription factor that initiates interleukin-2 production and promotes proliferations of the helper and cytotoxic T cells. This slide shows the mechanisms of actions of cyclosporine that I've been explaining in the previous slides.
Okay, so as mentioned by Fatimah just now, cyclosporine exerts its potent immunosuppressive actions on the T cells. So it has shown an excellent survival rate for grafts across many comparative studies. So it has said to be the most successful anti-rejection drug to date.
The usage of cyclosporine are pharyngeal surgeries, bullous pemphigoid, chronic transplant rejection, severe active rheumatoid arthritis, and also nephrotic syndrome. For your information, the first 2 points are the major disease that affect the oral mucosa.
So, the complications or the side effects of cyclosporine are dizziness, headache, unusual growth of body hair, nausea or vomiting, diarrhea, stomach upset or flushing may occur. Unusual growth and swelling of the gums may occur as well. However, brush your teeth and floss daily can reduce this problem. This medication can raise your blood pressure as well. Thus, check your blood pressure regularly and tell your doctor if the results are high, because the doctor may control your blood pressure with prescribing medication for it.
Another steroid-sparing agent is dapsone. Dapsone is a sulfone antibiotic with anti-inflammatory activity, primarily against polymorphonuclear leukocytes. The drug inhibits neutrophil toxicity and chemotaxis by blocking the myeloperoxidase activity. Dapsone acts against bacteria and protozoa in the same way as sulfonamide, that is by inhibiting the synthesis of dihydrofolic acid through competition with para-amino benzoate for the active site of dihydropteroid synthetase. The anti-inflammatory actions of the drug is unrelated to its antibacterial actions and is still not fully understood.
Okay, next, dapsone is a drug that is primarily used for treatment of leprosy, but also commonly used for treatment of bullous pemphigoid for its steroid-sparing effect, which is reported an efficacy rate close to 84% either alone or in combined therapy with systemic corticosteroids or other immunosuppressant. Another drug that is commonly used to treat bullous pemphigoid is azathioprine, which will be explained later. And actually, numerous studies have suggested that the adjuvant use of immunosuppressant shows some steroid-sparing effect, thereby helping to reduce the total dose of systemic corticosteroid that the patient needs in order to control the disease. So these two drugs are used for this purpose. The toxicity of dapsone, overdosage may be expected to produce nasal congestion, syncope, or hallucinations.
Next is the usage of dapsone. such as Pfeffingus vulgaris, bullous pemphigoid, leprosy, and also oral lynching planus.
The common side effects of dapsone are dizziness, headache, ringing in the ears, nausea and vomiting, and increased sensitivity of the skin to sunlight. However, the serious side effects of dapsone includes unusual fast breathing and heartbeat.
Tacrolimus is the neuroimmunosuppressant that acts by inhibiting T-cell activation and cytokine release. It is available in 0.1 and 0.3% ointment form. Tacrolimus, or formerly known as FK506, reduces peptidyl prolyl isomerase activity by binding to the immunophilin FKBP, which is FK506 binding protein, creating a new complex. This FKBP-FK506 complex interacts with the inhibits calcineurin, thus inhibiting both the lymphocyte signal transduction and interleukin-2 transcription. Although this activity is similar to that of cyclosporine, the incidence of acute rejections is reduced by tacrolimus use over cyclosporine use.
Okay, for tacrolimus, it has similar activity to cyclosporine, but rates of rejection are lower with tacrolimus. It is also more potent than cyclosporine, which is 50 to 100 times more potent. For the median lethal dosage is 134 to 194 mg per kg in rats.
Next is the usage of tacrolimus, such as oral lichen planus. Second, indicated for prophylaxis of organ rejection. Third, liver transplant. And the last is heart transplant. For information, the first point is specific to the oral relations.
Tacrolimus ointment may cause side effects such as skin burning, stinging, redness, or soreness, but some side effects can be serious such as swollen glands, skin rash, crusting, oozing, blistering, or other signs of skin infection, and also swelling of the hands, arms, feet, ankles, or lower legs.
Lastly, Metatrixis. Metatrixis is an anti-metabolite that suppresses DNA and RNA synthesis during the S-phase of the cell cycle. Patients should be started on a low dose, often with an initial test dose that is cautiously increased every week to the target dose. Metatrixate enters tissues and is converted to a metatrixate polyglutamate by follyl polyglutamate. Metatrixate's mechanism of action is due to its inhibitions of enzymes responsible for nucleotide synthesis, including dihydrofolate reductase, thymidylate synthase, aminoimidazole carboxamide ribonucleotide transformylase, and aminophosphorybosyl transferase. Inhibition of nucleotide synthesis prevents the cell division.
For the pharmacodynamic of methotrexate, it inhibits enzyme that is responsible for nucleotide synthesis, which prevents cell division and leads to inflammatory actions. It also has a long duration of action and is generally given to patient once weekly. Also has a narrow therapeutic index. For the oral LD50 in rats is 135 mg per kg and 146 mg.
Next is the usage of the methotrexate. So the usage are for bullous pemphigoid, head and neck carcinoma, rheumatoid arthritis in adults, severe psoriasis, and also leukemia.
Per kg in mice.
One of the complications or the side effects of methotrexate is unusual bleeding. Symptoms can include vomit that contains blood or looks like coffee grounds. Second, liver problem. Symptoms such as dark-colored urine, vomiting, yellowing of your skin or the whites of your eyes. Third, kidney problems. Symptoms include not being able to pass urine, decreased urination, and blood in your urine. Fourth, pancreas problem. Symptoms can include severe pain in your abdomen, severe back pain, and upset stomach. And lastly, lung lesions. Symptoms such as a dry cough that doesn't produce phlegm, fever, and shortness of breath.
Okay, now we can jump to the case report that related with our topic. During the scheduled visit to dental office, a 54-year-old male was diagnosed with bullae in vestibular aspect of right maxilla. He was reported to the outpatient department of oral and maxillofacial surgery. With the chief complaint of bullae, he has no history of difficulty in swallowing food or any eye sign problem. On general physical examination, there were not any complaints and findings. On intraoral examination, a solitary intact bullae measuring about 5 mm in diameter was present on the upper labial mucosa. In figure 1, no other bullae and vesicle were found. Based on the patient's history and clinical presentation, a provisional diagnosis of mucous membrane pemphigoid was considered. After the rupture of the bullae, it left large, superficial, ulcerated, and denuded area of mucosa.
The definitive diagnosis of this case is mucous membrane pemphigoids, or MMP. It is caused by autoimmune, and there is a participation of epithelium basement membrane-directed antibodies. On microscopic examination of the biopsy, there is a separation of epithelium from the connective tissue at the basement membrane area, resulting in subepithelial blisters. There is also presence of chronic inflammatory cells and eosinophilic within bulla. On direct immunofluorescence, reveal a continuous linear band of immunoreactants consists of IgG and C3 at the basement membranes. These antibodies may bind to proteins associated with hemidesmosomes, which is also known as bullous pemphigoid antigens. For the differential diagnosis, it is very difficult to distinguish mucous membrane pemphigoid from bullous pemphigoid, linear IgA bullous dermatosis, or epidermolysis bullosa acquista. But there is a distinct clinical findings of mucous membrane pemphigoid. We look at the serum target antigen. You can see bullous pemphigoid antigen 1 and 2, laminins 5 and 6, type 7 collagen, and before integrin unit. It is also involving conjunctiva, nasal esophageal, pharyngeal, and vaginal mucosa. Clinically, histologically, and immunologically similar with bullous pemphigoid but different in site of involvement, with bullous pemphigoid usually involve skin, while mucous membrane pemphigoid involve mucous membrane. For the treatment, it will involving the steroid-sparing regimen, in which systemic immunosuppressive medication such as prednisone is used. Prednisone is one of the glucocorticoid and one of the steroid-sparing regimen, which will be given in daily doses, and plus with alternative day therapy to reduce the corticosteroid complications. If azathioprine will be added if the patient does not respond to the prednisone alone. And there is also alternative therapeutic agents such as tetracycline, niacinamide, sulfite derivate, and dapsone. In such severe cases, we will be prescribing prednisone and cyclophosphamide. In conclusion, the chronicity of the disease covering significant morbidity to patients. Long-term corticosteroids and immunosuppressive therapy will also contribute to the morbidity for patients with bullous pemphigoid. Because of the heterogeneous pathogenetic mechanism, the treatment is depending on the lesional distribution and it is more individualized. Thank you.